I made my own notes, you know, and that's like some people would take their own notes to clinical with them, and that's how they would go through their physical assessment. Others, when you get to the clinical site, sometimes they're going to have, the nurses there are actually going to have their own checkoff sheets. I'm sure you guys have seen that. A lot of you have seen it if you've been in nursing homes or worked on the floor. They already have these little assessment sheets, or in the computer, you know, electronic. But you just go through checking, you know. So everybody's going to have their own way that they come up with to do their physical assessments. And the main thing is that it gets done, and that you don't miss anything, and or learn from that mistake if you do make it. On these validations, the most important, there's a bunch of important things, but it's huge to state what you're doing. I can't read your mind. Nobody else can either. Whenever we inspect, okay, say we're inspecting our patient, if you just look at your patient and say, okay, well then I'm going to start palpating. I don't know what you're inspecting. And that's why there's a lot of information written on these things, because you need to say, I'm going to be inspecting their eyes for drainage, their ears for drainage, or any redness, or da-da-da-da-da, okay? Does that make sense? You got this. If you don't say it, we don't know that you're doing it, okay? And that's how you're going to get credit, is by saying it out loud. This validation is going to be a little bit different than your other validations. In the meaning, as I'll explain this as many times as I need to. I'll explain it once right now, but if there's any questions, ask them. But then we can go into further detail if anybody doesn't understand, okay? So, you're going to be given a scenario, all right? Because as a practical nurse, we don't do head-to-toe assessments on patients, right? We do focused exams, exactly. So, in the past, they've decided, well, we try to get everybody to do a full head-to-toe assessment. Well, then when you get to clinical, that's what you want to do. And then your mind's already set into that. So we're trying to get you guys to realize, hey, I'm looking at my patient. They come in last night. This is what's important, and this is what I need to examine when I see them. That makes sense? So you're going to get a scenario. It's going to be typed out for you, okay? And let's say we had a patient that came in. They fell last night because they lost consciousness and they scratched their leg, okay? So, okay, what exam would you do? A neuro and an integumentary, okay? Does that make sense? Another scenario. You got somebody come in last night. They were examined last night by the admitting doctor. They had shortness of breath and chest pain. What are we going to assess?
Respiratory and cardiac.
Exactly. There's going to be 2 focused exams for everybody, okay? Whichever scenario you get. But you have to tell us what you're going to be doing, okay? Don't let that bring anxiety up, okay? I'm going to say that. Because what we're going to be there, okay? You don't let that create a bunch of anxiety. But you do need to be aware of, what you are going to assess. Okay? Once you've determined those 2 systems, then you're going to start your validation. Everybody, on this sheet of paper, you see the 2 asterisks under assessment. You see there's 2 asterisks at gather general data. You see there's 2 asterisks at implementation. Everybody will do those steps, because that's the beginning steps of a physical exam, no matter what kind you're doing, okay? Then you get into body systems. You got head, neck assessment. That totals out to be 38 points. You got to get all those points, as you validate, we check off if you do those sections of that assessment. Does that make sense? Neurological assessment. That's going to total out to be 38 points. But once we add up everything, your 20 points are going to be a the double asterisk, right? And a post. There's going to be another double asterisk at the end of the physical assessment. If you look at toward the end, closure. Double asterisk. That is going to be your ending, okay? So there is a point system in place The beginning and ending is worth 20 points total. Choosing the correct body system total is worth 4 points. And then each body system's 38 points apiece for doing 2. That all equals out to be 100 points. Am I making some kind of sense?
Mm-hmm.
Okay, and if there's any questions, just ask, okay? Because I'll clarify it any way that I can.
And we don't know our scenario until we come in to do it?
Absolutely, you will not know it. You can get some practice ones, which I've already given you 2. Practice, but it'll be a little bit more in depth. It's gonna be like getting a report, okay, in a sense. So everybody will do the double asterisks, then you will choose 2 assessments by your scenario, okay? Is there any questions so far about how the validation is gonna take place? Go ahead.
Is there a penalty for choosing the wrong assessment?
I want to say one more time, I'm not trying to be cute, I'm being just as serious as I can be. I don't want that to create any anxiety for anybody. Because we're gonna be here, y'all are learning. We're gonna help y'all through the process, but don't let that be a way out. You need to understand why you're doing something, because you're not gonna be a good nurse if you don't understand why you're doing it and who you're doing it for and the reasoning. You can't always depend on that other person that was before you to, oh, well, they did a neuro and an integumentary, so that's what I need to do. Things change, because when you walk into your patient's room, what you're doing from the very beginning, as soon as you walk through their door, you're assessing them. You're not listening to their chest, but you're assessing them, you're assessing the situation, you're assessing if they're on oxygen, what kind of devices they have, if they're on the floor. You're assessing from the time you walk through the door, okay? So don't let that create anxiety. We're gonna be there. Y'all are learning, and we're gonna help y'all get through it, okay? So don't let that create anxiety at all. Choosing the 2 systems, okay? We're gonna expect you to know it, but we'll be there, okay? Okay? All right.
Dr. Jackson. Okay, so let me just make sure I'm clear. Each person gets 1 scenario with 2 body systems.
Each
Right.
person will get a scenario.
Okay.
Within that scenario, there's gonna be 2 systems that
That we
need to
have
be
to
examined.
pinpoint. Okay.
Mhm.
At first, I
Now-
thought you meant we were each getting 2 scenarios. Okay,
One scenario, 2 systems for each scenario. Now,
Okay.
I can create a reason to examine every part of somebody's body if I think hard enough about it. What's your 2 main that come to mind? Does that make sense?
Mhm.
Okay. 1 scenario, you read it. Okay, I'm gonna be doing a cardiovascular assessment and a respiratory assessment. All right, let's go. Okay? If not, then I'm gonna prompt.
Okay.
Okay, remember there's that prompt word that we can do, okay? All right. Any other questions? So we're gonna start out with, I got a scenario, okay? I've told you guys, I've read it, I'm a student, okay? I've read it, and I say, okay, I'm going to do such and such exam, okay? Now, the difference with me today is I'm gonna do a head-to-toe physical assessment, okay? Because I've gotta show them all to you. But y'all know at the end of those double asterisks, you're gonna be picking 2. That make sense? Okay. So I'm in my actual validation, I've read my scenario, and then I'm gonna start my validation skill, okay? As we start out from the beginning, we've determined our focus assessment, which is gonna be 2 systems. What are we gonna do? Wash our hands, okay? We're gathering our equipment that we're gonna need for our assessment, okay? So I'm gonna do a full assessment, so I have all my equipment here, I've got it, I've gathered it up after I've washed my hands, and then I'm going to go ahead and go see my patient, okay? I'm knocking on the door. Hey, Mr. Jones, how are you doing? I'm Andrea Jackson. I'll be your nurse today. Can you tell me your name and date of birth? Okay, thank you. I'm going to be doing your physical assessment today. Can you tell me where you're at and the date of today? Okay, thank you. Good. And then also providing my privacy. See, I already forgot one step. Provide privacy. That's gonna be part of what you guys need to do as you're walking through the door, okay? We've explained it to him. Again, now that I'm ready to start my assessment, it's good for the patient to see us washing our hands. That's important, okay? As I'm walking through the door and I'm talking to him, I have all along been gathering data on him. I know that he is this is a thin male, Mr. Jones. I've already determined his level of consciousness. And then I'm gonna say out loud, he seems to be having a pretty good day today, because guess what? How am I gonna know if you assessed his mood?
By the way you respond.
Is he responding?
Mhm.
You got to say it, okay? He seems to be doing good today, he's in good spirits, or he's not saying anything to me. And then, of course, assessing his pain level is always important. Any kind of physical distress that he may be in, his appearance and clothing and hygiene, okay? All these things are what you need to be assessing. This is general, chapter 13. It's at the beginning of your chapter. This is the general data that you observe when you walk in, as you're taking your patient to the room, or as you walk in the door with your patient, okay? Then, before touching the patient, we're gonna warm our hands. It's on our checkoff. I'm warming my hands, okay? And then I'm gonna assist him to the position needed, which he is where I'm gonna need him for right now, and draping the patient. So I've got my blanket here. I don't know that you're draping your patient. I have my blanket here. It's gonna be used to keep my patient draped, and then I've got my gown up top, so I've got everything I need to do to keep my patients warm and not feeling, exposed. Now, that's all of our implementation, okay? That's all of those 15 things that we have to do from the beginning, okay? Now, we're gonna get into our actual assessments. Now I'm gonna do a head, start out at the head, okay? When we assess, what are the techniques that we use to assess? Ma'am?
Palpation, auscultation.
Inspection, palpate, percuss, and auscultate. Those are our 4 techniques, okay? We always start out with inspection, then we palpate, then percussion, and auscultate. Now, we don't use all 4 techniques with everything we do, right? Correct. Very important to remember that. So, I'm gonna start out with, I'm sorry, go ahead. Okay, I thought somebody said something. So start out with a head and neck assessment, and that's gonna include the scalp, the eyes, ears, nose, mouth, neck, okay? I'm inspecting the eyes. We're gonna be looking for any kind of drainage, redness. If they have contacts, glasses, we're gonna assess in their ears for any drainage, any buildup of cerumen. Pressure ulcers, where's a place where patients a lot of times can get pressure ulcers? It's the ears and the back of the head, okay? Assessing all that. So, and we're not through. I'm glad you pointed the back of the head, because we're not through with this head assessment until we do look at the back of that head, okay? That's important. We've inspected, so next we would palpate. When you're inspecting and palpating, symmetry is very important, okay? So you're wanting to make sure that everything's symmetrical, whether that be pupils, whether that be ears, or, chest. That's going to be something that you're going to be looking at all along, okay? And then going to the eyes, we're going to assess for perla. Does anybody know what perla means?
Pupils equal reactive brown.
Okay, so how do we see that? So I see obviously right now one pupil is larger than the other one, so they're not equal. But let's say that they were, okay? So pupils equal, reactive to light, so that's shining that light right there into that eye, and y'all all practice this on each other, but when you shine that light in your eye, the pupil is gonna get smaller, okay? If you watch the other eye, the pupil will get smaller also, okay? That is a part of this technique, okay? So pupil, it constricted, I check both sides. We're also gonna be looking for that pupils equal, reactive, or equal, round, and reactive to light, and then accommodation. So how do we check for accommodation?
They do it at the same time, like they accommodate each other, like one does it, then the other one does it.
Make sure you can follow.
Follow.
There's a few different ways to do it. This is the way, the most, like, this is the way the book teaches us, okay? Having the patient look at an object here, and then moving it out. Here, and then moving it back in. If you'll do this to one another, you're gonna watch the pupils constrict, and then they dilate, okay? So what we're doing is looking for that accommodation, meaning the pupils are accommodating for the distance of the device, okay? So that's just, and it's in your book, okay? Holding an object up and moving it, I think the book has moving it from here to here, but it can be either way, moving it from here to here or from here to here, and watching those pupils dilate or constrict, okay? So that's Perla. We've already checked our ears, inspected our nose for any kind of drainage, sores, breakdown. What's their speech like? Any kind of swallowing difficulties, tracheostomies, anything like that. Now, honestly, when y'all are doing this head to toe assessment, I don't expect y'all to say every single one of these, and I'll talk to Ms. Melton about it. But I gotta know that you're assessing them and what you're looking for, okay? We're not just looking at the eyes and moving on to the chest. Does that make sense? We're looking at the eyes, nose, mouth, throat, checking for symmetry, the thyroid, things like that, to make sure that it's equal on both sides. So we've done inspection, and then you just seen that I palpated, okay? Checking for any tenderness, enlargements, or any kind of venous neck distension. Has anybody ever heard of that? Venous neck distension? There's this whole way how to test it, but what are we doing?
Just feeling it.
Palpating it, feeling
We're just
it.
doing a basic exam, okay? This is not something that we're gonna get into all these instrumentation in time as we do more and more physical assessments. We're gonna build on the things that we can do in our technique, okay? But this is basic, okay? But you can look a lot of times and check venous neck distension. Sitting in this position though, not many people are gonna have venous neck distension unless they're in bad shape, okay? It's kind of more of a little bit lower angle that you literally check it in, okay? So now we've done our head assessment. We're gonna go on to the neuro. Now, if in my validation I had a head exam, let's say they fell and hit their head, so I'm gonna do a head exam and a neuro exam, right? What's the first two things on the neuro exam?
Perla and level of consciousness.
And I've already done them both. What do I need to say?
I've already
That you've already assisted.
Do not expect me to know that you know that. You state it. I've already done my Perla, I've already done my level of consciousness. So I'm gonna move on to checking the rest of my neurological assessment, okay? Which is going to be, what happens whenever somebody's in a car wreck and they sever their, let's say they have neurological damage, what can they lose function of?
Movement.
Limbs. Sensory, they can lose motion, because that's what nerves, we can't move without a nerve, we can't feel without a nerve, okay? So we're gonna be checking for strength. There's a few different ways to do that, and this can get very detailed. That gets to the neurology side of it, okay? Main thing is grip strength. I wanna see y'all do grip strength, okay? And say, you can say, don't let me move your arms up and down. And if they can hold them, that's pretty good, That's that basic neuro exam, okay? We also want to be checking for the strength of the lower extremities. What I'd like to see you do, all right, push on my hands. All right, they push their feet down, okay? Pull my hands back up. They push this up, okay? Don't let me move your legs. Okay, good. That is a basic neuro strength exam, okay? Then we're also going to do, can you move your arms okay? All right, because what could happen if they have neuro damage? They may not be able to move very well. What happens if somebody has a stroke? sometimes they lose that function on one side. So we wanna see, can you move, okay? Can you pick your legs up for me a little bit? Just something, I know that you're having them to move around some, that they are still have function and have some range of motion, okay? And then last is going to be, you know what I didn't do?
But you was.
See, y'all already failed me. Need to put these gloves on. It's on the validation. I do not wear gloves when I examine somebody. But if I walk into a patient's room and they've got soiled linen, what am I gonna have on?
Gloves.
So put them on. Don't do like me and fail, okay? So,
I got a question.
uh-huh.
So if you catch yourself with this deficit of the thing,
You catch yourself, I'm pretty lenient on it now. I'll have to talk to Miss, we like for all the steps to be done, we like for them to be done in order. But if, you know, and we'll just have to, that's something I can get more in depth about Miss Melton with, about, you know, but we'll talk about it, okay? But, gotta have these gloves on for this check off, okay? It's in here, and I missed it. So next is gonna be sensory, alright, and you can always use cotton balls, it doesn't matter to me. It works when I'm doing an exam and testing for sensory, I just lightly touch their hands. Do you feel that equally on both sides? So what have y'all seen me doing?
Grip
Both
shot.
sides, it's not just one, okay? So touching the same place on each side, yes, I feel that, okay, great. That's our sensory to light palpation down here. You feel me touching this equally? Yes, I do. Okay, that's our sensory to light palpation down low, okay? Upper and lower. Then we also gonna have our cardiovascular assessment. Okay. So, does everybody know where you listen to the chest whenever you're listening for heart sounds?
Yes.
How many places are there?
4.
4. Some people wanna get difficult and say 5. But 4. Does everybody know where they're at? I'm gonna expecting y'all to tell me where they're at.
1, 2.
Because I can lay a stethoscope anywhere just about in this vicinity and hear a heartbeat. When we hear lub dub, what are we hearing? What's the literally like the physiological,
Or opening and closing.
but what's the noise?
The cannot.
Love dub.
What creates the noise?
The valves opening and closing.
The valve's doing what?
Opening and closing. Or it's pushing.
Closing.
Oh, that's right. You hear them
Okay,
close.
and y'all are getting there, but is the literal closing, okay, of the valves. That's why whenever we're listening to the heart sometimes and we hear love, you know, those odd, eerie sounds that we can hear when we're listening to the heart, it's those valves leaking, because that's when they're shutting, and then we're hearing those odd noises. Okay, when we're listening to the heart, which intercostal space, do we wanna be over the ribs? I'm listening.
Clavicle to the fifth intercostal space.
That's gonna be which one?
It's gonna be it's gonna be
Mid-clavicular line to the fifth intercostal, okay? Now, on these mannequins, you know, you're just gonna say, okay, I'm gonna be, what's our first one? What's this one over here?
That's the
Our aortic,
aortic.
So, which intercostal space will be at?
The first.
Second. Second intercostal space at the sternal border. Meaning right, you know, we got our sternum, you feel the hole there, that's the second intercostal space. So here's our aortic, here's our pulmonic. What's the aortic? The aortic valve, that's why it's called the aortic, because we're listening to the aortic valve, pulmonic valve, okay? Then we get down here, where are we at? Which intercostal space are we at with these down here? 5 for both of them, okay? One's at the sternal border, one is at that mid-clavicular line. Which one's at the mid-clavicular line? What are we gonna do to it?
When you listen to the heartbeat.
And count them, right? Okay, so, doing my cardiovascular assessment, I'm going to auscultate my heart sounds, because for all I know, you're listening to the lungs. Say it, okay? When we listen to the heart sounds, listen over here at the second intercostal space. It's gonna be my aortic. second intercostal space on the left side, pulmonic. Which valve is right here? Sternal border. Which one? Look at myself and make sure I won't tell y'all wrong. Tricuspid, and then which one is over here? The apical. Which valve is the apical?
The apex of the heart.
Apex of the heart, the mitral valve. Okay, so that's the one that we're looking at over here. So second intercostal space at the sternal borders. Fifth intercostal space at the sternal border. Fifth intercostal space at the mid-clavicular line, okay? That's listening to the heart, 4 places, and then we're gonna listen to the apical for that full minute. You know, invalidations, in my opinion, you can say, I'm gonna listen for a full minute to get an accurate pulse reading, or actual heartbeat reading, okay? You can say that out loud, I don't expect you to sit there for 60 seconds and hold it, okay?
So, okay, but these, we're not doing them on each other? This is in person?
You're gonna be in person, but as far as actually doing it on someone, Miss Melton, are they gonna be doing the physical assessment on their partner?
No.
Okay, so you're gonna be on a mannequin, okay? Now that we've listened to our heart, and listened to our apical pulse, then we're gonna be noting quality and rate, okay? Is it loud, is it soft, is it muffled? And then the actual rate, okay? When we listen to, I'm so glad I read that. So when we're listening to the heart or lungs, where do we listen? What do we do with this gown?
Lift it up, we listen under the ground. Skin to
Mr. Jones, I'm gonna be listening to your heart, okay? And I need to go right up underneath your gown, okay? Under the gown, never, ever, ever over, okay? Heart and lungs, both, and GI. Always listen under the gown. Because this gown, I don't know if y'all ever listened to over a gown, but you can hear the noises of it, and it will change the interpretation of what you're hearing, okay? Now, what's next we're gonna do is we're gonna palpate for pulses, right? Which ones, in chapter 12, y'all went through that. Where all pulses are we gonna palpate? How do we get to our carotid? Okay. You can go midline if you want, and then dropping off to the side. Do we ever feel both sides at one time? No. Okay, so here's our carotid. What's next?
Brachial.
Where's our brachial? That's a good place.
But I thought it was
But it's
more-
literally gonna be about right up underneath you. It's hard to feel it on yourself. You just about have to get somebody like this. And you're gonna feel a dip. You feel that dip where I'm at right there. Right there. Where are y'all feeling it?
Right here.
I feel right there.
Yeah,
Well,
you
then
can
do what
actually
they say.
feel it right here.
I can go right here.
This is the brachial. I always feel it here.
So where's
Okay.
so if that's the brachial, then where's the ulnar?
Ulnar, you're probably not gonna feel ulnar. Ulnar's really hard to feel. Ulnar, so bone, radial side, ulnar side. Ulnar, some people you can feel it on. Okay, so brachial, we'll stay there. Don't listen to me because that's where I feel it, okay? Now,
So are we gonna get counted off if we feel it here?
no, you feel it if they said this is brachial, then that's where you feel it. And we'll look in the book in further detail. If anybody's got theirs, great, that'd be good right now, but if they don't, we'll look it up. But I've always felt here, okay? But that's still gonna be right there along that artery, okay? So brachial, what's the next one?
Radio.
Thumb side. What's next?
Femoral.
Okay, where's our femoral?
And right below the groin.
It's gonna be right in the groin. Right here, right in the groin.
I can never feel on that.
Popliteal.
Behind the knee.
A lot of times what it's best to do is kind of bend that knee up just a little bit and feel right, it's normally gonna be right in the center, okay? Very rarely can you feel one. Somebody has to be very thin to feel it. Where's our posterior tibial?
Coming out.
Back of the ankle. This ankle.
What side's our tibia on and what side's our fibula on? So posterior
Inside.
tibial,
Inside.
posterior tibial right here, behind that tibial, that malleolus right there. And then where's our dorsalis pedis?
The top of the foot.
Top of the foot. Okay. And then while we're down here, what else are we gonna be looking for? But we're gonna be looking here. You can always look for edema where? You can look for it in hands. You can look at it in the perineal area. And in the legs. Mhm. And then also, what else do we wanna check? To check our, cardiovascular status. And where would we wanna check it?
Fingers and toes.
Nail bed, a lot of times people say nail beds or the tips of the fingers. I've done both. How quickly do we want it to respond?
Less than 3 seconds.
Alright, so bilateral, you don't have, and I'm just gonna say it. It's good to do both, but if you say, I'm going to do both hands and you do one, I'm going to do both, I'm gonna do both feet and do one, I'm not that concerned. I know you're saying it out loud, okay? Any questions about cardiovascular? Where are we gonna listen?
Under.
Under.
Oh, under the gown.
Where are we gonna put our gloves on?
Before.
Okay. Now, we're also gonna do, and I wouldn't wanna leave my patient uncovered like that, okay? Keep them covered up. And now, we're gonna go to respiratory now. Where are we gonna start with? We're gonna start with inspection, right? I didn't inspect my chest on cardio, right? It's the way it was set up, honestly. Whenever with this sheet was done, but respiratory, we're gonna do more of an inspection and palpation, okay? Inspecting the chest. What are we inspecting the chest for?
Skin color, bilateral rise and fall.
What about one side is lower than the other?
Yep.
What if when they're breathing, you see this side's rising and this side's staying where it, what if they're breathing from their abdomen? That's a concern, okay? So inspecting, palpating for any kind of crepitus or, deviations of. Now, when we're assessing the chest, would we want it uncovered? I'd prefer, if I'm gonna be assessing the chest, really, anytime we're inspecting, we need to see skin, okay? Because how would we know if there's not a mass or an infected area, or let's say, and a lot of times, and it's even red here, you see a lot of people get yeast, especially in the nursing homes. If we're not uncovering them and looking at them, how are we gonna know what's going on with them? So when you inspect, you're looking at skin, okay? Looking at skin. So inspection, then we cover that patient right back up. Checking for a cough, use of accessory muscles. And then, once we've inspected and palpated, what's next?
Listen to the lungs.
Auscultate, okay? How many sites are there that we listen to on the front and the back and the sides?
10.
10. Okay. Your book has them played out for you rather nicely. It's got a good picture in there, okay? So how long are we listening?
30 seconds.
One full respiration at each site, right? Okay? So until your patient needs you to breathe in and out through your mouth. That decreases the noises that go through the nose, okay? So I want you to I'm gonna listen to your chest here, and I expect y'all to be talking more to this patient than I am, okay? Because I'm doing my best. I'm trying to teach y'all and try to talk to them, and it's making it a little hard on me, but I want y'all to be talking to your patient, okay? I want you to take a deep breath in and out. So there's 10 spots. Now, do I expect you to sit here and say, I would say, I'm gonna listen to 10 areas. I'm gonna have them to breathe in and out, and I'm gonna listen for a full respiration at each area. My areas are 1, 2, 3, 4. Now, when I do this, am I doing here, here, and then here and here? How am I doing this? Side to side. Here, here, same side, opposite side, okay? Till equal 10, okay? And then we want to cover them right back up. Now, do we have to listen to their back because they're laying on it?
Yeah.
All right, I'll have you set up for me Now, we're listening to the back. Where is our spots that we don't listen to? Do we listen over bone?
No.
Okay, what's back here? Two big scapulas, they're protecting our lungs from the back, okay? So we wouldn't be listening over here on top of the scapula. You mind standing up for me? Somebody, I'm gonna show somebody, I just want to show them. Okay, what's over here? What am I on? Bone. So it's here, if you will, and you don't have to do it. Take a deep breath in and out through your mouth and listen for one inspiration full. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Is the lungs down here?
Mhm.
You can even feel ribs. I'm not trying to be picking at you, but you don't want to go, that's where our lungs are going to stop about right here, okay? So 10 in the front, and we're not over the chest area. We're more in the center, and we come out. There's a reason for that. Then there's 4 locations. Here, 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 and then here. Your book shows it's a good picture, okay? But remember, we're not going to be on top of the gown. We're going to be under the gown, okay? So we've listened. What are we going to be listening for?
Crackles.
I'm sorry.
Crackles.
Yeah, when we listen for any kind of adventitious breath sounds. So we're going to say we've listened to the lungs, they're clear, and then we place that stethoscope in all the locations that it needs to go, correct? Okay. Next is our GIGU. Those are together, okay? So what's that mean? If you get a scenario with abdomen, you're going to be assessing the GI and the GU is what that means, okay? They're all right there together. You're going to be pretty much all doing but assessing them anyway, okay? So I'm going to have to listen to your stomach here, so I'm just going to have to uncover you a little bit. And so when we start with the stomach, what are we going to do first?
Look and see if it's
Inspect.
Look at
Do we ever reach over our patient?
No.
So what did y'all say? I'm sorry.
It's not just in here to flat.
Do we really listen to the stomach when I'm sitting up?
No, they need to be laying down.
Maybe be kind of laying down some, okay? All right, so we inspect first. What are we looking for?
Stinking,
Mhm.
round,
Flat,
any marks, bruises.
any osteomies, infection, rashes, anything like that. So we inspected. Now, next step is to do auscultate. Where do I start?
It's the in the first quadrant.
Which one?
It's the
Lower
upper
left.
right.
Upper right,
No, it's upper left.
Active?
It's upper left.
it's upper.
I believe it. I've read it was right lower.
Okay. Okay, yeah, okay, right there. Upper right.
We need to read on that more.
I think
I'm
it's
pretty
upper
certain the book said right lower,
Upper right.
It's low or something.
but we'll clarify that between now and then, okay? So, right lower, how long do I listen?
A minute.
5 minutes of absence.
It's,
Anywhere from 5 to 30 seconds,
yeah, 5 to 30.
right?
You should
How,
be-
no, how many, I'm done. How long do we listen?
2 to 5 minutes. 2 to 5
Okay,
minutes.
what's a normal?
That's if they're absent. I think.
Yeah, this is
Normal 5 to 30?
Yeah.
Gurgles, okay?
Mhm.
But if we can't hear anything, we listen up to what?
5 minutes.
Okay. And so we listen, so we draw off our quadrants, right? Belly button,
Mhm.
and then down the center. So listen in here, listen in here, listen in here, and then here. How do we document? Normal, hypo, hyper,
Mhm.
right?
Normal thought.
Okay, so we've listened. As far as, I just want to make sure on that 5, yeah, 5 minutes is how long we listen for absent, if there's not any present. So what's next to do?
Palpate.
Palpate. So what kind of palpation are we gonna do?
You're gonna lock the person to the stomach.
Have they talked to y'all much about deep palpation?
Nope.
Yeah.
And I wanna talk to Miss Melton. I didn't put it on this, because there are certain times you don't deep palpate. And Ma'am?
If they're having pain, you wouldn't.
Right, you don't wanna be, especially if they're having pain just with light palpation, you know? So I just put light on this, and that's what we're gonna do, okay? What are we noting while we're palpating?
If you feel anything abnormal, like a lump or.
Lumps, masses, tenderness, pain, okay? And then, what are we gonna ask the patients?
What was the last bowel movement?
Was it normal? What did it look like? The color, consistency? What else are we noting?
If they're continent or incontinent.
Exactly. If they have, you know, or any kind of like garments that they have on for that. And then, along with that, urinary status, color, odor, when's the last time that they had had they urinated, and then whether they're continent or incontinent of urine, okay? And then we've got our integumentary. Now, pretty much all along, we've been looking at that, you know, but when we do an integumentary, there's one thing that's not on here that is coming to my mind, but I would hope that, you know, everybody knows we gotta look at the back too. We gotta do a skin assessment. You can't just look at the front, okay? So I'm gonna be expecting, if you get an integumentary assessment, even though they get an abrasion on their knee, or an abrasion on their head, that still gives you skin. And what includes skin? It includes the integumentary systems front and back, okay? So expect both sides. So we start out with inspecting. What are we inspecting for?
Color.
Color.
Okay, it's something with
Texture,
your
dryness.
skin, and then we're gonna be starting here and going to legs, okay? Uncovering, and looking, I'm gonna have to show you your chest for just a minute, and take a look here.
I got a question.
I'm listening.
When you inspect the skin, when you started at the neck for skin tucker,
Start at the neck, what?
for skin tucker?
I have it last, but you can. If you do skin turgor first, I mean, that's not a big deal. But I just put it last on here. But there's nothing wrong with doing that. Inspecting the skin for any alterations, abrasions, tears. I'm gonna get you to turn on your back, turn over on your side now, and take a look at your back. We're looking at the back. And then the backs of the legs too, okay, y'all? And then I would need to go to the other side, because I can't see I couldn't see this hip. Turn you to your other side. Okay. See anything there? And or there's an abrasion to the knee, has a slight purulent drainage to it, you know, and then document on that, okay? Scars, pressure ulcers, surgical incision, drains, rashes. This is things I want y'all to be saying out loud, because I need to know what you're looking for.
Would we know for tattoos also? Like, wouldn't we verbalize?
I took it off, but you can.
I
was trying
just
to-
knew that at one point in time, like in Marine school, we had to, so I just
Yep.
didn't know.
It's good too. Good to note that. Now, we're back to we're at our closure ending. So you're gonna get 2 of those exams. Okay, you're gonna do two of those to choose from, okay? And at the end, we're gonna help get this patient back comfortable again. Do you have everything you need? You have everything you need. He wants to be set back up, so I'm gonna set him back up. Removing my gloves. And then, of course, he's not an infectious patient, so I'm okay to remove my gloves and touch that. If he was infectious, would I have taken them off yet?
No.
Discard these. When I ask if they have any questions, we're gonna document. And then what's that last thing?
Report to the charge nurse.
Findings.
Am I gonna say all those things out loud?
Yes.
Because how am I gonna know you do it unless you say it?
Yeah,
I
you
won't.
can't read them all.
One down.
Okay. Now, when you're saying, you know, I'm inspecting, just going back to something on this integumentary, when you're inspecting the skin, you know, I'd say I'd check front and back, you know, I'd check front and back. But remember, this is 1, 2, 3, 4, 5, 6, 7, 8. That is 8 steps worth 38 points.
It's a big deal.
Okay? So you be doing some talking. I am checking for that. You think of anything that be on that skin. You say it. You say it out loud.
What she said,
And I see some
somebody said something about 60, what was that again? The skin turtle?
How long it takes for the
And
skin to
thank you.
release
You
back.
said that. How do we check skin turgor?
Pinch the skin.
Watch how long it
To
takes
see
to go
how
down.
long it takes for it
Chest
to
is a
flatten
good
out.
place to do it. How do we chart it?
To see how long it takes for it to flatten out.
Skin
Quick
turtle comes-
If it takes-
or delayed
Yeah.
response? You can. I've always, that's been a big deal to me. Always is how do you chart turgor?
Do you want us to put seconds,
Check
but how long
the
is it?
skin turtle response. So say that,
I'm sorry.
so say when we do it, say we're gonna check the skin turtle
We're gonna,
response.
we're gonna check their hydration status, and the way we're gonna do that is by checking skin turgor. And then we're gonna be assessing the briskness of the return of the skin for the tinning of the skin. Does that make sense?
So my question is, if the skin turgor is greater than 3 seconds, do you want us to put skin turgor greater than 3 seconds?
And you know, I've done a lot of reading on that. Skin turgor, they've not ever really made it. It's a poor. It's an assessment we use all the time, but it's not a.
Needed assessment?
It
Is
can
it
tell you if
valid?
your patient dehydrated.
Yeah, it can tell you if they're dehydrated.
There's no what's the word I'm looking for?
There's no like baseline.
There's not a, you know, it's like a capillary refill, less than 3 seconds. Because everybody's skin turgor is gonna be a little bit different.
That doesn't
It's,
make
it's
sense.
just not a real definitive way of determining a hydration status. It's good, it's good, and we still do it, and we do it just on this, you know, and people do it all the time, but it's not your best indicator. Your labs are gonna be your best indicator of dehydration status, but yeah, charting that, doing the turgor, okay? This is a good spot. Hands are not, because mine's never gonna go down. I've washed them so much, it's just sticks up, so. Going back to this cardiovascular assessment, there's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 steps for 38 points. It's just a very important that y'all, you gotta do those 15 steps to begin with, those 5 steps at the end. But those 2 assessments are huge, okay? Worth lots and lots of points. So just make sure y'all are comfortable with them,
For
okay?
respiratory.
Does anybody have any questions?
We can't, okay, this is a lot, I know it's a lot, I know it's a lot. We can't get our scenario beforehand?
No. We've gotta know how to
Because
do
that's,
that.
because then we'd be just practicing those 2 instead of learning all of them.
We need to know all of them, we're just not doing all of them for the check off.
And then the universal beginning and end steps, do we need to state those with this? Because a lot of that stuff is in here.
That sheet, I mean, the sheet that says provide privacy, wash hands, introduce yourself.
Go by the
everything,
sheet.
so.
I mean, Miss Milton does like, that's something y'all need to be used to saying. Y'all need to be, yes, it's important to do all those things, because that's how we care for our patients. You know, whether it would fail somebody, I can't answer that. I'd have to talk to Miss Milton more about it.
So do it.
Are we almost done? Cause I have to be somewhere at 4. Just do it. Are we almost done? Cause I have to be somewhere at 4.
It's 3, we normally get through at 3, don't we?
Yeah.
Okay. I'll ask Miss Milton, make sure she doesn't have anything else for you guys. As far as I know she doesn't, I'll ask her real quick. Any questions? Anything y'all can think of?